Good day, everybody. Depending on where you're joining us, good morning, good afternoon, good evening. As we have more people continue to join the room, let me briefly introduce myself. My name is Glenn Ko. I am an education associate with the Sing Health Duke-NUS Global Health Institute, based in Singapore, where we also host the Asia hub of the Mental Health Innovation Network. That's what's bringing us all here today. Um, I want to thank you all for joining us at our very first webinar that we're hosting with MHIN Asia. While the network itself is not too new, the Asia Hub release was established late last year. And these webinars are part of our efforts to spotlight global mental health work coming out of the region and encouraging knowledge sharing within the region. So we are still learning how to navigate our various regional needs, priorities, and time zones. So we will have a feedback form at the end of this webinar, and we'd love to hear from you there as well. Just some other quick housekeeping before we begin. You should be able to see a Q&A box on your Zoom bars. Please use that to let us know if you have any questions for our speaker today, and we'll save some time at the end to try and answer as many of your questions as we can from that box. So today, we're very honored to have Professor Brian J. Hall speak to us about the promise of scalable digital mental health innovations in the Western Pacific region, lessons learned from adapting and implementing WHO's step-by-step program in China. Professor Hall is a professor of global public health and the founding director of the Center for Global Health Equity at NYU Shanghai, an affiliated full professor in the Department of Global and Environmental Health in the School of Global Public Health at NYU, and an associated faculty member in the Department of Health, Behavior, and Society at the Bloomberg School of Public Health. In 2017, he was the inaugural Global Mental Health Fellow of the WHO, where he participated in the formulation of the scalable mental health programs launched by WHO, including Step by Step, which we will share more about today. As a recognized authority on mental health in China and the Western Pacific region, Professor Hall has served as a commissioner on the Lancet Commission for Mental Health in China and has hosted trainees in China from the US and other countries, engaging them directly in community-based research. His dedication to global health mentoring was recognized with a Faculty Excellence in Advising Award from the Center of Global Health at the Bloomberg School of Public Health. He's also an elected fellow of the American Psychological Association and was inducted into the Delta Omega Honor Society for Public Health. I could go on about his many accomplishments and achievements, but I'll stop here for now. And I'll hand the time over to you, Brian.
Okay. Can you see my slide and hear me? Okay.
Yes, we can.
Terrific. Well, first I want to, thank the Mental Health Innovation Network Asia Hub and our friends at Duke NUS Sing Health for inviting me to be here today. This is a real honor to be the first first speaker in this series, and I'm sure we're going to have so many other amazing presentations that are going to come through from the region, and we could really learn together about what's happening and what kind of innovations are happening here in the Western Pacific. So I'm going to discuss our work on scalable psychological interventions here in China, and specifically discuss this step-by-step program that WHO has created. Okay, so first I want to start with kind of setting the scene a bit. So we know that the Mental Health Atlas is a compendium of the resources available for mental health in the world. It's the most comprehensive resource for global information on mental health, an important tool for developing and planning mental health services within countries and region. And it's updated periodically every few years. And what we see from this slide is that there's enormous global inequalities in the distribution of mental health human resources, and they remain true year on year. What we see is that there are inequities between low and lower middle income countries and high income countries with regard to the distribution of availability of mental health carers, right? So these are people that could provide psychological intervention and evidence-based treatment. So there's a huge treatment gap that exists around the world. In the Western Pacific region, we have about 15 and a half per 100,000 people to serve the needs of the region. We also look at the global health workers breakdown. the median per 100,000 people, we look at this to see, well, who's providing the care, right? And what we notice is that mental health nurses are actually the ones that are providing most of the mental health services globally. And in the Western Pacific region, that number is actually 68% of the mental health workforce. And what that means to me is that a lot of the care that's being provided is hospital based. It's not community based, community oriented. And although psychiatric nurses are terrific carers and practitioners, they might not be delivering evidence-based treatment. We know that psychologists and psychiatrists are actually a much lower number of providers. We also know that there's a number of key barriers to accessing mental health services. And in China, we did a systematic literature review to find out, well, what are some of those barriers? We published that several years ago. So we looked at attitudinal barriers, so negative attitudes towards help seeking, poor help seeking experiences, distrust, preferences to handle issues on their own, cultural barriers, so fear of discrimination, fear of losing face or stigma or public stigma, low perceived needs, so including trying to handle mental health problems on their own, and families' opposition to help seeking, and structural barriers, so not having again this access to care that's desperately needed. I was a part of the Future for Mental Health in the Western Pacific region. We convened a meeting in 2023 to kind of launch this framework, and it's available online. So I just want to highlight that and just speak through a few overarching kind of themes that came up. So the new vision for mental health in the Western Pacific region is a region where people can enjoy highest level of mental health and well-being, grounded by social solidarity for transformative environment that promotes health for all, which sounds absolutely terrific, and I think can provide a really great kind of framework for us to be thinking about, well, what's happening in mental health and what's going to happen going forward in the region. There were three different areas that were touched on. That was refocusing the agenda, transforming, and embedding. And I'll just talk about that just for a second. So we think about refocusing the mental health agenda. We want to include well-being. So well-being, in addition to mental ill health, we also want to think about understanding wellness and well-being in addition to that. We also want to identify the unreached. The thing I want to highlight here is that there are a number of populations in the region and globally that are systematically left out of mental health care. Those could be migrants, migrant workers, LGBTQI populations, and other minoritized groups that aren't really centered in the mental health dialogue. So I think this document and this framework really helps us to refocus the agenda to make sure that we're reaching all of those that need care in the region. Also, we want to think about transforming the mental health care and think about developing a co-design ecosystem focusing on person-centered care. And this really starts speaking to this innovation and thinking about innovative technological innovations for delivering mental health services at scale. When we think about mental health services, there's this optimal mix of services that WHO has promulgated, where we think about folks at the lower end of the service need continuum, where self-care and guided self-help interventions could be extremely useful. Most of the people with mental health conditions, common mental disorders like anxiety and depression, could benefit from low intensity psychological interventions, and including self-care. Not everyone needs to seek treatment from a specialist. We know that those specialist providers are few, and so we want to think about developing interventions that could reach the largest number of people and provide lower intensity psychological care that could be scaled up more easily. We know that there's been a lot of innovation around task shifting, where people without specialist degrees, without advanced educational opportunities, can be trained to deliver psychological intervention within the community settings and communities in which they live. And that task shifting approach has been quite effective and useful within global mental health. But considering the kind of advent of COVID and what we've experienced over the last 4 years now, we know that digital interventions have been taking up a lot of ground. WHO looked at scalable interventions a number of years ago as a new kind of like focus of their work. And so they developed a number of packages of care and programs that can be scaled up and used by lay health workers in a task shifting approach, but then also used by individuals in a self-help framework. There are a number of different interventions now, and it's actually quite remarkable to see over the past roughly 10 years how many of these interventions have been developed and trialed, and WHO approaches this in a really, in a rigorous way because these are all global public goods. I mean, one of the interesting and exciting opportunities in working with WHO on any of these programs is that once two definitive RCTs are conducted and there's positive trial evidence for the usefulness of the intervention, the effectiveness of the intervention could then be given away as a global public good. And so that's true for all of these manuals, and a lot of them now are becoming openly available and easily then adapted for use in different countries and for different populations. And these are principally available on the website and available freely for download. Step by step, the program I'm going to talk about today is not yet fully available and accessible online, but it should be soon. So we'll talk about digital mental health interventions. So digital mental health interventions are promising because they could be culturally appropriate in the language of the end user. So it kind of overcomes this very key barrier that we see in terms of access to care, which is that even if there are mental health providers, they might not speak the language of the folks that need the care. So that's especially true within a migrant context when people are migrating internationally for work or as refugees or asylum seekers. They might encounter a context that has mental health provision, but doesn't have linguistically informed care. And I think that's an incredible barrier that can be overcome through digital tools. It also minimizes stigma because an individual doesn't have to seek treatment within a specialty clinic. It's economically viable and accessible. Most people now have a smartphone and broadband access as much as it's been challenging in some regions. And there are still regions of the world and folks that don't have access to smartphones. But by and large, I think the majority of the population, based on available data, 80–90% has broadband access, even in more remote areas. So I think that's a gap that's being closed. We also know in terms of the evidence, so this one systematic systematic review meta-analysis showed that 36 unique RCTs, that the evidence suggests that digital interventions using apps can reduce anxiety and depression symptoms with a small to moderate effect size. And in another RCT or another systematic review with 13 studies of RCTs, the evidence to date indicates that digital mental health interventions can reduce moderate to severe symptoms with a moderate effect size. We often think about utilizing digital interventions and self-help interventions for folks that have common mental disorders, like I mentioned, like anxiety and depression, but that also have mild to moderate symptoms. So this RCT is actually, or this system meta-analysis is showing actually that there is evidence for use among folks who have more severe issues as well. And we know that it's not inferior to in-person treatment as well. This is kind of an older review, but nonetheless shows that there is a non-inferiority with digital mental health interventions and in-person care. Early in the pandemic, our team worked with the Western Pacific regional office of WHO to conduct a rapid review of what was happening in the region in terms of responses to COVID and mental health mobilization. I'm not going to go through this really systematically, but we found that there was 174 unique interventions across 22 different countries and territories in the region. And there were key gaps. So there were few interventions that were available for people with serious mental illness and substance use, and uneven distribution to vulnerable populations. So, for example, we know that during COVID-19, migrant populations in particular were left out of a lot of care. and opportunity for mental health treatment. We identified a number of different key dimensions here, but the thing I want to really focus on is that we did find that over half of the interventions, unsurprisingly, were delivered digitally. And there were 12% of the interventions that we looked at were actually delivered through apps or websites. So there was a period of rapid mobilization of resources and innovations that were stimulated by the pandemic. So people really got active in their communities and try to deliver mental health services to folks. And most of these online interventions, actually, a lot of them were developed with chat lines and hotlines, with some telemental health as well. But I think at this point, we are pretty open to the idea of online services and digital intervention opportunities. And COVID-19, as much as it's been an incredibly difficult period for all of us, I think it has provided the impetus for us to think about pivoting forward and developing a service or multiple types of services on digital platforms. We also know that there's been an increase in the prevalence of common mental disorders, especially among youth. And this meta-analysis showed that 29 studies, including over 80,000 children and adolescents, that the pooled prevalence was over 25% for depression. And so that was a significant increase from before the pandemic. And new data is always coming in, and we're looking at these kinds of trends developing over time, and trying to understand, are these trends continuing, or do we have a reversing of this global trend? In China, we looked at the evidence for depression and found this meta-analysis of 113 studies and over 185,000 students, and found that almost one in three, so 28%, had a common mental disorder. So it's an incredible prevalence when you think about the number of students in China. And this is pre-pandemic. So the number of students in China that need a mental health intervention is quite significant. And what we know from China and also from other places in the world, that student counseling centers are universally overwhelmed by the number of people that need psychological care and support. That was only made worse, of course, during COVID-19. So we're trying to think about now, and really we're stimulated to think about interventions that can be scaled and delivered to really reach this population without the burden of trying to increase a workforce, which might be just absolutely impossible to achieve. So, that brings us to the Chinese step-by-step program. And it's a scalable, guided WHO digital mental health intervention that we adapted for Chinese young adults. The goal is to reach the Chinese population. It could be scaled up to mainland China. So at the time that we were working on this, we did this work in Macau, China. And Macau, China is an interesting location in China because it has both Mandarin speaking and Cantonese speaking Chinese young adults. And so it's an interesting place to kind of conduct a randomized trial with the ambition then to scale that intervention to Hong Kong and to the Greater Bay Area of China, which is a population size of about 68 million people, and it includes all of Guangdong province, Hong Kong, and Macau. It's primarily targeting individuals who are surviving adversities, and then we developed intervention that could be used in diverse communities. This intervention program is not particularly designed for Chinese audiences. This initially was developed with the idea to address mental health of refugees in Syrian refugees in Lebanon. And actually, this intervention program has been trialed in multiple different countries already. And that trial evidence suggests that it's an effective intervention to address the needs of very seriously conflict-affected and traumatized populations as well. And actually, the Lebanese Ministry of Health has incorporated it within their ecosystem of care. So there's already evidence of this intervention being trialed and also utilized at the Ministry of Health level in a country, which is very exciting. And hopefully we can see that same innovation taking off here in the Western Pacific. So just to talk about like what is this Chinese step-by-step program? What is step-by-step? It's an intervention that has 5 sessions, which are 20 to 30 minutes long. It's delivered by a smartphone, tablet, or on a website. It also has minimal weekly peer support, which I'll talk about in just a moment. This 5 session intervention is based primarily around behavioral activation, which is an evidence-based treatment for depression principally, but it does have transdiagnostic features and opportunities. That is, that it could address depression, but it also has evidence that it could address other psychological issues, including post-traumatic stress disorder. Minimal evidence, but it has a transdiagnostic component. It has 5 sessions, so stress management, planning activities, reducing avoidance coping, self-acceptance, and relapse prevention, which is really about mobilizing social support, which I think is an incredibly important aspect of a psychological intervention. To mobilize supports and resources in the community so people can continue to receive support and care after they've completed intervention. Behavioral activation is a treatment that I'm sure many of you are already aware of it and familiar with this treatment, but it effectively it effectively imagines that an individual has depression because they don't have excellent reinforcements in their environment. And the idea behind behavioral activation is to re-engage in activities that a person enjoys and engage within their lives in such a way that it increases reinforcements, positive reinforcements from others and from the activities that they're engaged in. So the participants are shown the text and images that relate to a story where one character shares the problems and how they were helped, how the program helped these problems, and another character explains key concepts. It's guided by peer support, and we had a Mandarin and Chinese version. So I think it's important to consider utilizing, there's a lot of discussion now in utilizing peer support or utilizing the expertise of people with lived experience and co-creating and co-facilitating interventions. So that's been something that I think over the past couple of years has really become an attractive topic that people are discussing pretty often in global mental health. So I think in this model, we utilized what we have referred to as lived experience peer support. We trained a cadre of university students, many of whom have suffered with anxiety and depression symptoms themselves. We trained them to provide weekly technical support and assistance to individuals who are going through the app. And this provided a great opportunity to increase the kind of self-mastery, self-esteem of those individual learners, the people that were involved in the peer support activity, and then also provide the support that would be needed for individuals to complete the intervention. I think, we looked at evidence, and there's systematic reviews that show that self-help and self-help interventions are actually more effective if they're guided. So if there's someone that can actually help them to complete the sessions and coach them along the intervention. So that was also part of the program here. So there are 4 different components in our overall work on step by step. We did a cultural adaptation, marketing design-a-thon, a feasibility study, and an effectiveness implementation RCT. So I'll take each of these different phases one-on-one. First, we want to talk about cultural adaptation. So cultural adaptation is the systematic modification of an evidence-based treatment or intervention protocol to consider language, culture, and context in a way that is compatible with a client's cultural patterns, meanings, and values. And that's Gabriel Bernal's seminal work and contribution to this field, and a framework that has been used in step-by-step trials, and we used in this cultural adaptation work. We want to make sure that the content is relevant, so it's related to the cultural group, it's acceptable, so that nothing will be offensive to the cultural group, and also comprehensible, so that it could be understood easily. And that is beyond just language, but also comprehensible in terms of the frameworks that people understand about mental health. I'm going to pivot a bit and talk about our Filipino version of Step by Step because we actually did the adaptation in two different populations. So one was the Chinese version, and then the other was the Filipino overseas Filipino worker population in Macau. So I'll walk through the cultural adaptation process, animating it with this Filipino version. So the first step in the process was interviews with senior experts. So we interviewed three Filipino psychologists that were expert at understanding and treating issues within the Filipino community, and particularly the overseas Filipino worker population. We conducted online interviews. We consulted their opinions on the content of the program. We were starting with a program, which is really often the case in global mental health, where we start with an evidence-based treatment, and we do a cultural adaptation of that treatment for a new population, right? And so we started with an intervention program that had been developed, like I had mentioned, for Syrian refugees, which is a very different cultural context and population than Filipino OFWs. So we first wanted to seek the advice on how we can make the adaptations and make the story something that would be more relatable, non-offensive, and comprehensible. Based on the feedback that we received, we rewrote all of the intervention material, taking their advice as a new starting point for the intervention. We then conducted 16 different focus group discussions, 7 with men and 9 with women, with 28 OFWs. So the men were from a diverse background, food and beverage, hotel and casino, facility management industries. We had 16 women in our focus groups, many who were domestic workers, also from food and beverage backgrounds as well. And they participated at least once. We had focus groups with 2 to 11 participants, and we conducted at a university and an NGO. In these focus group discussions, we iterate on the content and the images of the digital intervention. And so we requested their feedback through a cognitive interviewing approach. We wanted to understand um, um, what they felt about the content, if they thought the content was clear, what it meant to them. So we had think aloud questions where they would tell us in their own words what they thought the content was referring to. And we really worked with them to develop the images so that the images were and the characters were relatable to the population as well. We adapted illustrations with a professional illustrator, using those original illustrations as a starting point. And then we translated to text with a professional translator and developed a new content iteratively. So we would go to the focus group discussion, we'd show images, we would get feedback, we'd go to the illustrator, we'd go back to the next week, we would show the new adapted illustrations and get additional feedback, and continuing to iterate on that process until the community was satisfied with the content that we developed, and that we knew that it would be relatable to them. So, for example, here we had in the original on the left, we have the original content, spending time with family. But in the OFW context, it's difficult to see, family reunification doesn't happen often. It sometimes doesn't happen for years. And so a lot of the family events and important activities that are shared with friends and family are done online. And so we adapted the content directly to demonstrate that this character is having a birthday with her daughter back in the Philippines, and that's all being done online. We also went through different wording and phrasing. They, for example, in the original, skills was discussed, but folks didn't like that, so we wanted techniques instead. Suffering was changed to being stressed because it sounded less grave. Using drugs as a negative coping was removed because of the kind of difficulties that were happening back in the Philippines with regard to the quote war on drugs, and how negative that and evocative of negative emotionality that was for the folks that were in our focus groups. And staying in bed all day was also removed as a negative coping because it just doesn't resonate at all with folks who are migrant workers and working a tremendous amount. Drinking alcohol as a negative coping mechanism was changed to drinking too much alcohol because it is normative to go out with friends. They felt like having alcohol should not be vilified universally. So those are just some examples of the adaptations that we did with the Filipino community. And of course, we publish that, and we have a lot of illustrations and content that can animate that further. We also went through a similar process with the Chinese step-by-step program, where we had 6 Chinese psychologists, and we adapted the text and illustrations based on their feedback, and then went through another 18 focus group discussions with Chinese young adults in Mandarin and Cantonese, male and female focus group discussions to adapt and change our content. Um, Here in the original story from in the refugee context, a parent passing away was one of the key stressful factors. And in our adapted version, we have a parent got sick or a big fight with a girlfriend or boyfriend, which was much more common and thought to be a more universal stressor among Chinese young adults and college students. And we also added the story of academic pressure and how academic pressure can really become a key stressor to live up to parental expectations, to live up to teacher expectations. So really kind of centering this idea of filial piety and respect for elders as well, and also included this idea of a free rider, so that a student who is as a part of a group project, which is very common, doesn't actually carry their weight, and that's a huge stressor. Um, Here are some illustrations that we had made changes to make it more relatable. In the first slide here, or the first image, you see two male characters who are discussing issues that were upsetting. And our male participants in our focus groups felt like, that's not really what young men are doing when they're talking about stressful events. So we adapted it to show 2 young boys playing video games together, which is commonly what guys do in terms of, they compete and they talk together while they're engaging in activities. So we adapted that content. Here we have another illustration of a young woman who is kind of standing there feeling upset, but the focus group didn't feel like this really captured what a young woman would do, and so they felt like this more adapted version resonate with them more. Um, I think one of the other key adaptations we made across both of these programs is to remove the professional characters. And I think this is a really important point because in the original step-by-step program, the Syrian folks really wanted to see a professional physician character providing the intervention content to really feel like it was a professional program. But in the Chinese version, they felt like having those medical doctor characters was stigmatizing, and they didn't want to see a physician or a professional. So they wanted to see an elder sister with a professional background. So within the Chinese cultural context, it's very common that younger people within research teams or within academic settings will refer to a more senior person in the context for advice and support. And so we incorporated that within the program. The male focus group didn't want a human character at all. They actually felt much more comfortable to have this animated non-human character. So we made the adaptation for that. There's a number of different adaptations we made that were gendered as well. And I think I just wanted to illustrate here that we really were able to kind of capture male and female illustrations based on the focus group discussions we had, and based on the content that we created, and what they felt was what really resonated and was not offensive to them. So moving forward, we conducted a marketing design-a-thon. The reason I want to highlight this is because I think we really want to highlight the idea of co-creation and working with the population that will ultimately be served by the interventions that we're doing, and really work with them in concert to create intervention content, which I've illustrated so far. All of the content that we adapted and all of the intervention materials were created in collaboration directly with the communities that we hope to serve. But that is only one side of the equation. The other side of the equation is, how do we actually promote the intervention? How do we engage people who are potential beneficiaries in the intervention through a marketing plan? And I think we often forget that that's an important aspect of this. As academics, we don't think about marketing and as a business plan, right? But I think we have to be thinking about making sure that we could reach people. So in the designathon, in this outline here, we have an orientation. We had a 2 to 3 day workshop, and on day 4, we had a contest. So what do we actually do? We created a number of different pieces of a marketing plan. So we had an icon, we had a short video, we had a poster, and so students actually understood what step by step was. It was a great way of kind of teaching people about digital mental health, about the promise of digital mental health, also the app and what the app was intending to do, and engage them in developing this resource. So we had a number of judges as well. So we had judges from the community. We had local politicians. We had people from the student affairs office. We had students from the university. And then we also invited students from different universities across Macau, and they all came as well to be judges. So it really provided an opportunity to bring a lot of key stakeholders together to think together about this program. Yeah, so we had a lot of people that came to this event. And when we think about innovation, this was the first digital mental health intervention that had ever been attempted and trialed in Macau. And it was the first intervention trial of a digital mental health intervention, or a WHO scalable psychological intervention, in China. So there was a lot of potential barriers to cross to get people to kind of understand the aims of the project, and also to effectively buy in and support the work that we were doing. Once we see the promise of this type of intervention and opportunity, people were champions of this. And of course, it wasn't possible to carry out the project without a lot of support from many folks. So following the Medical Research Council guidelines, we did a feasibility study. And in the feasibility study, we had a small uncontrolled pilot trial where we were able to show really a large effect size improvement on depression symptoms pre-post. Also a large effect size difference in anxiety symptoms as well. And so it was really a promising, and Cyclops is a kind of a user-defined, like a participant-defined set of problems that they hope to change through an intervention. So we found that it was well accepted. There was no negative side effects. And the findings suggest that the program could be feasible within a larger scale up. I think it's incredibly important to conduct these kinds of feasibility studies because, again, this is a complex intervention. We wanted to conduct a full-scale randomized control trial, and we wanted to embed this within a university setting. So we developed a protocol and worked this out with the Student Affairs Office of the university. We had local NGO support. We had a research center in Macau also supporting this. And we put together an RCT effectiveness trial. And what is an effectiveness trial? So we know that efficacy studies are very well controlled RCTs, but one of the biggest critiques that we have in global mental health is that a lot of the studies that we've done in the field, and a lot of the trials that have been conducted, have really been one-off trials. So if you look at the literature on RCTs, on many of the task shifting interventions as well, there's excellent evidence that task shifting works. There's excellent evidence that complex psychological interventions can be deployed in complicated situations around the world. But if you look at that, those interventions, they've been deployed and trialed with enormous amounts of resources and personnel at the time of the trial, right? And so those really extremely well-resourced trials in tightly controlled settings show really high yield in terms of effectiveness or efficacy, rather. However, what you also notice if you look back at those trials, that many of those trials actually don't have follow-up data. So once the trial was concluded, the project team left, the intervention wasn't deployed at scale. And I think this is the biggest challenge that the field is facing. One of the biggest challenges right now is that the evidence in global mental health is really based a lot on these efficacy studies. So we're moving, and the field is moving to effectiveness studies and implementation science. And the reason that we're doing that is because we want to design interventions right from the very beginning that can be deployed within contexts and people live and work, play and age, right? And I think it's incredibly important that we make this shift in the field and that we design trials that will show evidence that are embedded within local realities. So we attempted that. And so just to go backwards for a moment, these different hybrid types, it's not necessary to kind of like delve into each of these, but we did a hybrid type 1. And the reason we did a hybrid type 1 is because there was initial evidence that the intervention was effective, but we had no evidence that it was effective within China or within Chinese youth. And so we wanted to evaluate the effectiveness of the intervention. At the same time, we wanted to evaluate how we could embed it within a student counseling center and within a resident college system at the university. Resident college system is basically a co-residential setting where undergraduate students are basically living together. And they have within each of those resident colleges, they have a number of services that are available to students. So we wanted to make sure that we can embed this within that structure. So quickly, I'll just go over the kind of outcome here. The outcome of our intervention was that we showed strong effects for depression symptom at post-treatment, but those intervention effects were not maintained at 3-month follow-up. We also showed improvements in well-being, both at post-treatment and at follow-up, and that some of the individual problems that were discussed as key issues to address were addressed at follow-up and not at post-treatment. So it's a mixed bag, basically. And these are all per protocol. So this is not intent to treat. What we see is that individuals who engage in step-by-step and followed the protocol and completed the sessions had a moderate excuse me, a moderate effect size reduction in depression at post-treatment and improvements in well-being, a moderate effect size at follow-up. When we look at the intent to treat, the effect sizes obviously are smaller because we had a lot of dropout. But what we look at here is that we did show a significant reduction in depression symptoms at post-treatment that's maintained, excuse me, but not at 3-month follow-up. And in terms of secondary outcomes, again, we see the post and follow-up psychological well-being. And within this intent to treat, we also saw anxiety symptom reductions. So what are the challenges? What are the limitations to the approach? We see that there's a high dropout rate. There were a lot of no-shows and early dropouts, and that's a pattern specific to digital interventions. I think the whole field, digital mental health, has to address these issues of dropout and lack and non-engagement in the intervention. I think that has a lot of promise for future work and research. We relied on self-report. There was limited follow-up time. The program may be too content heavy. So one of the issues that we're kind of grappling with now is step by step is how to take a 20 to 30-minute intervention and reduce the content to make it much more nimble, much shorter, and really match what a lot of young people are doing, which is using a lot of online intervention, online tools, online social media, which has like 20, 30-second clips, right? So we're competing with a different kind of ecosystem that people are in. And so we really want to kind of think about how to take step by step and reduce the content and make it more user friendly. Um, there were a number of promising results. So in terms of lessons learned, it was the first RCT on step by step in China and a scalable psychological intervention in China. We saw that there were depressive symptoms being reduced at post treatment. So we could see the velocity of change was higher than the treatment as usual condition, which was basically waiting for intervention and psychoeducation. It was a single session psychoeducational intervention. We saw that there are key challenges in terms of treatment completers. So there was only about a 40%, 36% treatment completers for step by step. And that's a bit lower than some other trials, but really in line with, again, the major challenge that we're experiencing in the field. There were a number of dropouts, though. We did a qualitative post assessment to find out, well, why did people drop out and what was their experience with the intervention? And what we found is that the lack of peer contact was really important. So I emphasized the issue about guidance earlier, and that we trained these peer supporters, but not all of the peer supporters were able to contact their participant. And when that didn't happen, that affected the trial outcome. So I think it's incredibly important that we refine that peer support process. We also noted that 77% dropped out before session one. So they were screened and could have benefited from intervention, but then we weren't able to capture them. So again, so emphasizing the importance of engagement really early on in the process. Um, so student organizations, in terms of training and expansion, this is a model that can fit within a student counseling center within the residential college system. So if a student presents to the clinic and has mild to moderate symptoms, which is what we were trialing in this study, they could be triaged to receiving step by step as a frontline care. And so when we have student affairs office was telling us that they have like 12,000 students, but they only have like four, or fewer counselors. And the caseloads are just really, really getting high. So this is an issue that's happening across China. And I think step by step has shown that it could be an intervention that can be provided as a frontline treatment. So individuals who come to care in a step care model can receive step by step. And if they don't respond well to that, then they could be stepped up to a higher level of care or a different package that might be more suitable to them. In terms of the delivery method, I think we relied on an app. This was another major kind of concern with our trial, was that we relied on an app instead of using WeChat, which is obviously a really well used app in China. And so again, situating the intervention content within the ecosystem that people use, I think, is incredibly important. So after now that we've done this trial, I think migrating the content to WeChat will really improve the user experience. So I tried to keep this within 45 minutes, and I think I have. There were many people to thank for their work on step by step in China, and this slide does not do that group justice, but many folks that were really key, and none of this work could have been possible without a great team and a lot of support. So with that, I thank the team, and I also thank you for your being here today and joining online. And I'm really happy to answer any questions. Here is my email and the QR code for WeChat. You're welcome to scan me or reach out on email afterwards. So with that, thank you very much.
Thank you, Brian. That was a great present. Oh, we're getting some reactions coming in. I didn't know it could do that. So you getting some applause here. Um, Kind of makes you feel like this is still in person. Um, yeah, I think we do have some questions that have come in throughout the session as well, and I was gonna ask you about some of them. Also tagging on some of my own questions for you. I think one question came in from Dominique talking about the cultural adaptation part of the process. Um, so they were curious about how certain themes were withheld, such as like the war on drugs and the alcohol. Like, were these advised by experts pre-focus groups, or what was that process like?
So this was, I mean, that's a great question. And I think there's always a challenge in terms of what content we include and what content we would exclude. This is not an alcohol-based intervention. So it's not about addiction. And we also want to capture the realities of people's lives. Often people do go out with friends and have drinks, and that could be something that is not does not reach the level of abuse or have the potential of really being self-destructive, right? So we didn't want to vilify a very commonly engaged in coping exercise. It was not advised by the experts to exclude that wording. But that's what our focus group discussion participants told us. I think there's always a disconnect in some way. I think it's great to consult experts, and as experts, we have a lot of knowledge about, mental health. And even as cultural brokers, I mean, we attempted to reach cultural brokers that had a lot of intimate knowledge of the community as well. But there's always going to be a bit of a disconnect, I think, between what experts might think and what community members might need or want to see in the intervention. And I think that's why it's really important to center the experiences of the community members themselves as we kind of think through what content to include or exclude in our interventions.
Yeah, I guess as a follow-up to that, like how do you determine the kind of the threshold for the amount of change that you're able to make, right? I know we talk about the behavioral activation stuff, but
Hmm.
how do you where's the threshold? How do you determine that?
Yeah, I mean, I think you're really the question is really challenging because I don't know that there's a clear answer to this question. And I think the field also is grappling with this, like how much cultural adaptation is needed, how much tailoring is needed for a community before the intervention can be effective. And I think um, we don't have clear guidance on this because doing a study that would have a culturally adapted version and a non-adapted version, or some kind of combination of those, tweaking those factors, I think is incredibly resource intensive, as you've seen with this adaptation process. It took months, actually. I did this work with Professor Melissa Garabiles, and the two of us together, sat in, all those focus group discussions and with the Filipino community, and it took us over 3 months to do it. So I think, and there's no real there's no real elegant way of testing these things in a trial context when we're trying to deliver an intervention. We were under a bit of pressure, especially during COVID, to kind of like get the trial out to the community. And Yeah, so I think we don't really. It's an empirical question that we don't have a really elegant way of solving at this moment. But I think there has been reviews that showed that like the more cultural adaptation you do, the higher the effect size for the intervention outcome in a trial. And so there is evidence to suggest that cultural adaptation is needed. And I tend to err more on the side of more tailoring and more adaptation for a community rather than having less adaptation. But that's more of my opinion probably than it is based on too much evidence. I think we need more evidence about that.
Actually, kind of related to that,
Sorry.
you've spoken about the results with the overseas Filipino workers and then the Chinese students separately. Have you done anything to compare the effects across?
So I didn't talk about the trial evidence for the for the OFWs, and that wasn't on purpose. I think we have a more complete story to share in terms of the Chinese step-by-step program, and we have a full RCT. During COVID, we attempted to conduct the RCT for the Filipino migrant workers and ran into a lot of difficulty with it. And I think the lessons learned there were many. One was don't do an RCT during COVID with a migrant population. But that kind of anecdote aside, I think it was really, really challenging. There were some technological issues. Again, like the app delivery itself. the platform that you use to do the intervention has to be really custom built for the community that you're working with. And I think we tried to use the same digital app that was used in other trials, other WHO intervention trials, because we were working in parallel to the stuff that was going on elsewhere in the world. And so we also benefited from being able to use that app because it was extremely expensive to adapt it and build a new app. But what we found is that with the OFWs, when they were downloading the app to their phone, it was exhausting all of their loading, all of the Wi-Fi that they had purchased. So then we had to kind of give them vouchers for more Wi-Fi. We had to get I mean, this is a very basic thing, but when we think through the intervention, we didn't anticipate this problem, and this became an issue in terms of getting people to download the full app on their phone. And we screened an enormous number of people. But then when we were able to when we tried to move forward with the randomization, we missed a lot of people. Again, it was COVID. So, there's a lot of kind of instability. People were moving back home. So the context of the trial was not ideal, frankly, for that RCT.
Yeah, that definitely sounds about right in terms of the difficulty of running an RCT during COVID. Um,
Right.
we had a couple questions come in, sort of relating to the peer support portion of the trial. Um, I guess one question from myself really is like, did y'all see any sort of impact on the peer supporters themselves in being a part of the trial and the implementation of this?
We know we did, and we've conducted a study. Actually, the social worker who was in charge of doing all the training with the peer supporters, Alice Hong, we had done a small sub study looking at the effects of participation, and we haven't yet published this study, but I think it's really an important story to share, because I think that when we look at network-based intervention, peer support-based interventions, we often just look and evaluate. We often look at and evaluate the outcome for the end user, but there is evidence from really early work and foundational work with people who inject drugs, for example. Network-based interventions show that people who are trained to deliver intervention actually have improvements to their own mental health, their own well-being, their own behaviors as well, their own health behaviors. So we did find that in the study, but we haven't published that. It's not peer reviewed yet. But an important story to share.
And then also like we've talked about the peer support portion being like a kind of a key factor in the retention of it. Um, Wondering as there's a question here, kind of like, so then in that case, do you think well, there's two parts to this. Do you think purely
Hmm.
self-guided digital mental health studies can be effective moving forward? Or is the blended approach always going to be necessary? Um, I'll ask the other one later.
Yeah. No, I think we're at a different moment right now. We're at the like generative AI moment. We weren't there when we started this work years ago. But now that we have different types of tools available to us, I think we could much more rapidly develop and test content of interventions. I think we could do different types of community co-creation using generative AI. So I think there's a lot of opportunity there. And the reason I mentioned Gen AI is that um, I think that it also could be potentially the case that we could automate some of that peer support. And so having like a chat bot that's kind of affiliated with it, or having like a guided self-help program that actually has some prompts associated with it that really are just in time and responsive to people's questions and needs as they go through the intervention, I think it is really promising. I think that's where we're moving at this point. This program was effective. It showed that it could reach people. It showed that well, Chinese young adults in particular, and it showed that it could be an effective intervention. But I think we need to start doing more innovation to digital mental health interventions, such as this one, to really reach more people. and to incorporate some of the new technology that we have now. I mean, technology is moving so fast. I think the field is struggling to keep up in many ways.
And that touches on the other question actually kind of the other question was kind of talking about like whether or not AI chatbots would be eventually be able to take the place of some of these like peer support structures. But kind of I don't know, you want to comment a little bit on like the losing the human connection aspect of it with these kind of
Yeah.
like chat ideas.
I look at this kind of like as generational effects as well. So people, there's no one born today doesn't have access, at least some accessibility or exposure to a digital world, or mobile phones or social media, et cetera. That wasn't true 10 years ago, or 20 years ago rather. So now what we're seeing is that, generationally, as people are kind of like, aging into the use of these different technologies, I think it's going to become much more normative. The new iteration of OpenAI's ChatGPT is really conversational. There's a conversational agent built in to the program. You can actually just engage it and start talking to it about issues that you're having. You could ask it to reframe, do cognitive reframing or cognitive restructuring, like a CBT therapist. And I encourage everyone to play with this because it's a really interesting kind of exercise to see how far we've actually come. These conversational agents actually can provide a lot of cognitive restructuring interventions and supportive interventions already. So I think we are at a different moment now, in thinking about how to incorporate that and how to use that to really co-create with communities, because it can also have a double-edged sword of not actually providing the content that is needed, or not having an evidence base. And I think, a lot of apps are on the market. And one of the other things about digital mental health that I should mention is that Step by Step is an evidence-based digital mental health intervention, based on, I think there's been 4 or more trials, 5 trials now, including the one I talked about in China. But most of the apps available in the App Store don't have any evidence at all. So we're still in this kind of, we still have this issue about making sure that the apps that are being used have very strong evidence that they're effective.
Great. I just want to be conscious of time. I know we're coming up to the end of the hour, and I'm sure we could keep talking about this. Um, just for folks who are still here, I've dropped a link in the chat to a feedback form, and I will also share a quick screen. So if you want to scan a QR code there as well, that's an option for you. Um, but yeah, I guess as we come to the end, we could have asked another question about what are your ideas about addressing the attrition rates and the dropout rates to this. And maybe we'll do that. But before we kind of more people leave, what's a kind of do you want to have like a final word about what you want people to take away from this presentation? And then we can add on more questions at the end.
Yeah, sure. So yeah, I mean, I think it's a terrific opportunity for me to be here. And again, I think the Duke Global Health Institute, Sing Health, Duke-NUS, Mental Health Innovation Network, for having me. And I think it's a terrific thing that you have, that you're working on. So Anne, Claire, Glenn, the work you're doing to have Mental Health Innovation Network here is terrific, and it's an absolute bonus for all of us. And I'm really excited about this. And thank you again. I think my reflections now about the future is making sure that we have people with lived experience, people who are potential beneficiaries, really working hand in glove with researchers. I think that should be the norm. I think we should be moving forward to conducting trials that are implementation oriented, that we know the evidence that we're creating actually has utility to serve the populations that we aim to serve with our work. I think these are things that should just be foundational. We haven't really figured out what the optimal strategies are in terms of incorporating people with lived experience and the co-creation ecosystem. I think there's a lot of potential for innovation there. I think there's a lot of potential for new work and for new frameworks to be developed, and I think that's an exciting trend. Um, and I think digital mental health remains a promising intervention. This tool can absolutely be used as a frontline treatment within student health centers and can show that there's an effectiveness with regard to the reduction in symptoms. So while we are not going to unlikely to solve the human resource capacity issue, and train enough providers to actually do in-person high intensity psychological intervention, this can serve as a great frontline treatment. I don't think it replaces people. I don't think it replaces therapists, especially for people that have, more intense needs on that spectrum. But I think it's a great adjunctive treatment. It's a great treatment that for many people might actually serve their needs. It might actually give them what they actually need and what they require. So I think that's a takeaway.
That's great. Um, So so in case anybody here needs to leave, this is a great time for you to jump out. At the same time, I just wanted to make a note that we are recording this webinar, and so if now is not a convenient time for you to stay on and hear some more questions, you can always check out the webinar recording. We will be putting it up on the MHIN website, and we'll probably email everyone who's registered so that they're aware that the recording exists. Um, but yes, otherwise, Brian, if you're happy to stay on a little bit longer, uh, I don't know what your schedule is like, but maybe like another like maybe
Sure.
one or two questions.
Yeah. Yeah.
Yeah.
Absolutely. Let's do it.
Uh, so I guess the one of the question. So actually, you were talking about like this is not gonna kind of replace the therapist. So I guess let me rephrase it. Let me rethink this in my mind a little bit. Um, I guess as you were carrying out the implementation as well, were there points? So there had a question someone asked, but were there points in the trial where people could also like kind of escalate and like seek more formal resources depending on kind of how the activity was going? Is
Yeah.
that
So
baked in?
one of the key Yeah, so I didn't mention this, but there was, with between session monitoring of symptoms of depression. And if there were cases, I mean, per protocol, if there were cases where there were exacerbations and symptoms during the trial, the peer supporters actually were then asked to provide a list of services for them. To provide, a higher level of care. So there were referrals if there were any kind of treatment exacerbations. We didn't have that in our trial. There was no case that we had to intervene or an issue of suicidal ideation, which is something, or suicidal intent, which we're always concerned about in these kinds of digital trials. We didn't have any evidence of that. So we didn't really need to escalate care.
Nice. Okay. I'm glad to hear that it wasn't well,
Hmm.
at least there wasn't any like major emergencies that arose during the trial. Um, we had another question. So we had the question about like, well, what are your thoughts about some strategies that you think would help improve the attrition rates for these sort of digital mental health interventions?
Yeah, I think one thing is getting the platform right. I think I mentioned that the app that we used was, I mean, it was already designed to conduct trials on step by step. And so we used it, but in the field, we had some challenges and bugs in terms of downloading the app, bugs in terms of, people being offloaded of the app on the app. I mean, these kinds of really um, basic things in terms of the technology and the delivery of the intervention absolutely needed. We thought we had solved them, right? But even in the conduct of our trial, we had more of these things come up. So that's really frustrating because we try to go slow, and we try to really do a really rigorous step by step approach to get this trial done. So I think that's the key for me, is to make sure that we have the app and the delivery system correct. Aside from that, though, I think the content is too long, and I think I mentioned this issue of competing with very short video messages. like Reels and Douyin or TikTok videos, etc. I mean, their eyeballs are just like glued on the screen. There's no trouble in terms of getting people to use this content. So I think um, whether or not we could replicate that for intervention, like step by step, is kind of an open question at this point. It's an empirical question as well, so people are welcome to try to test that kind of intervention delivery mechanism. But there's always issues in terms of trying to get the content right, the dose right. There is promising work that's also being done in the field of digital mental health that's single session intervention. So like really reducing from a 5 session program to reducing it to a single session intervention, and that might really meet people's needs in the moment. So instead of, walking through so this program basically you have to you take session one and then it unlocks session two and unlocks session three. By session three, maybe people are like, you know what, I've received the dose of the intervention that I want. And they're fine. Or they might feel like, well, I don't really have the patience or the determination to go through an entire 5 session intervention. For migrant workers in particular, I think trying to get them to use an intervention that's like 20 to 30 minutes long, utilizing Wi-Fi that they're buying, instead, so that actually might be really tricky. So again, I think to sum that all up, I think we need to have shorter duration in our content. I think our content creation, I would say that all of our inline qualitatives supported that the intervention content was really good. I have a lot of confidence that our cultural adaptation and the kind of work that we did to kind of fit the populations, like reflect the population in our work, I think that was really well done. But I think that the app itself and the length of the content needs to be adjusted for further studies. Yeah.
Would you say that further adaptation is your next step following all this?
It is actually, yeah. So I think we never were able to get a proper RCT conducted with the Filipino OFW community. And I've been working kind of like I talked a lot about digital mental health, but I've been working in the area of migrant health for many years. And as a trained, I'm a clinical psychologist, also, trained as an epidemiologist. And I want to do more than just kind of count the burden of disease in a population. So it's really important to me that not only do we do work that quantifies that burden, but then we also have an interventional aspect to it. And when we weren't able to conduct the full-scale RCT with the OFW population, that was challenging to me as a researcher, frankly, because I really wanted to deliver that as a benefit to the community that we have been working with for many, many years. So I think at this point, yes, we need to kind of retool and repackage step by step. And we've been seeking grants and trying to get funding, obviously, for follow-on work. We just published our trial, and it took many years. COVID was really disruptive to us and everyone, but we finally published our trial just this year. And we've been working on this for a long, like many years actually, to get to this point. So yes, I think we are at a new moment, and we want to utilize more advanced technologies and conduct, more adaptation work for our future studies. A lot of promise for that.
It's great to hear. I mean, I'm sure I think we can wrap it up now. We've taken up enough of your time.
Oh, it's
But
been great.
it's
It's been terrific.
it's really exciting to hear about the work that you're doing, and I'm sure there's going to be a lot of more amazing things that be coming out from you and your center and your team. And we can't wait to follow along and observe great work you're all doing.
Thanks so much, Glenn. Yeah. And thanks again for having me.
Yeah, thanks for being here.
Thanks
Thanks
to
for
everyone that's still online.
Yes, thank you everybody who's still here. We won't take up any more of your time. But check out if you want to recap anything, the recording will be available soon enough. And we'll email people about it. And please do the scan the QR code or click into the feedback form. We love to hear from you. This is our first webinar. So there definitely things that we would love to tweak and improve upon for subsequent ones as well. So yes, otherwise have a great day, evening, morning, whichever time zone you're in. Uh, and we'll see you at the next one.
Yep. See you guys there. See everyone there. Bye bye.